Otherwise, it is an SR.
Mhm.
Night, if required, he comes.
So, Saurabh, can we go live?
Yes, sir. Almost.
2 minutes, one and
Yes,
a
sir. You
half
can
Just
minute.
start now. It's live.
we can start.
Yes, sir.
1.5 मिनट है वैसे. Okay.
Okay. Anyways, yes, we can start.
Yes, please. Yes, please.
Okay.
Shall I start?
Yes, yes, yes. Please go ahead.
Okay. Good morning, everyone. Thanks for the kind invitation, Dr. Ghansham and Dr. Srinivas, my dear friends. Whenever I'm asked to speak at Hicks, we come better prepared because we understand it's a bigger audience and the expectations are big. Good morning, Dr. Srinivas. Good to see you.
Good morning. Yes.
Good morning. So the topic assigned to me today is toxidromes. No conflict of interest in terms of topic, product, or any intervention. I have modified the topic a shade to toxidromes in ICU because we all understand the basics of toxicology and toxidromes. So we'll try to understand what are these toxidromes, why are they required in ICU, how to approach an undifferentiated patient. The diagnosis is not very clear at times, co-ingestion and many more issues. So we need some approach for diagnosing toxicology patient. We'll understand the definition of toxidrome, how to diagnose the common toxidromes, and how to use our clinical judgment wisely, judiciously, while we treat this patient based on toxidromes. There are some basics which we should understand while we practice toxicology. First is time is toxin. The interventions are time sensitive. So we must think about poisoning early. At times they will come in some other forms. The diagnosis will be not clear. You might be confused whether it's a GBS, whether it's a stroke. So we must think about toxicology early. We must have a syndromic diagnosis early, and we must go for definitive interventions and treatments early. Treat the patient before treating the poison. Do not waste a lot of time in diagnosing what poison it is. Better focus on physiological stabilization first. Meanwhile, horizontally, you look at the cause, the etiology. ABC first, toxin second. So always focus on ABC. Do not be carried away. What toxin is this? If you have done your basics right, you have still some time to focus on what is the etiology. Diagnostics are most of the time very poor. Analytical labs are not available everywhere. Toxic screens have their own fallacies. So treat the patient, not the tox screen. Tox screen could be false positive or false negative many a times. Clinical science will overlap. Clinical science overlap between toxidromes. Clinical science overlaps with some other disease. History is unreliable most of the time. Newer toxins are poorly understood, they are poorly analyzed. Diagnosis, especially the lab diagnosis for newer toxins, is difficult and they are not picked up in most of the toxicology screen. Co-ingestion is very, very common. And always beware about the clinical complications from poisoning. A poisoning patient can meet with an accident, poisoning patient can have sepsis after 3 days, poisoning patient can have hypoxic ischemic injury. So don't take toxins alone. Think about the coexisting diseases, coexisting comorbidities, or new onset diseases in a patient with poisoning. Better the devil you know than the devil you don't. So you must finally arrive at a diagnosis. You should not be firing in dark. You should know what poison is it after stabilizing the ABCs. And now co-injections are increasing day by day. You have to fight the bigger devil first. The major killer you have to tackle first. The lesser devils you can probably have some time to work on. Diagnostic accuracies. This is a bigger challenge in toxicology. Toxicology diagnosis often relies on a combination of clinical features, circumstantial evidence, the history, the trips they bring, and the lab testing. Lab testing plays a very, very minor role, although we want the analytical toxicology lab to be everywhere, but still we have it in very select centers. Unlike infections or metabolic disease, no single test confirms all poisonings. Having said that, this does not happen in infectious disease. There is no single test for most of the diseases. Diagnostic accuracy determines appropriate antidote use, supportive care, and prognosis. So we must have some sort of diagnostic accuracy, whether it is from the clinical diagnosis or it is from the lab corroboration what we have. So diagnostic accuracy is influenced by many factors. History, unreliable, we all know that. Clinical presentation could be non-specific symptoms seen in many poisoning, coma, seizures, acidosis, common presentation, hyperthermia, hypothermia. These are common presentations for poisoning. Lab confirmation is limited. We will discuss in some detail later on. Timing of exposure is often not known, which again confounds our analytics. Plasma urine level obviously vary with time, especially for paracetamol or salicylate. Delayed sampling reduces the detection probability. Co-ingestions and polypharmacy are major challenges for analytical toxicology as well as for clinical diagnosis because many signs will be masked or modified or signs of two toxidromes can be present. This is our very old publication. We did this in Indian Journal of Anesthesia in 2011. We analyzed 1 year data of our toxicology patients in our multidisciplinary ICU and we published this in 2011. This was profile and outcome of patients with acute toxicity admitted in ICU experience from a major corporate hospital in urban India. We had 138 toxicology patients. Out of this 138, 32 was co-ingestion. And the co-ingestion has increased gradually over these years. There was an increasing variety and complexity of toxins because we were in South Delhi and we had many clubs and bars close to us. So we were seeing newer and newer designer drugs. Substance abuse attributing to a significant number of cases. Newer drugs, which we never heard about, we have to actually Google about those drugs, 8 out of 138. So you have to remember this, the pattern of toxicology is changing. We do not have clean cases like clean cut organophosphate or opioid. We have a mixed ingestion most of the time and patient could be a chronic abuser of drugs. Non-specific clinical features is again a major diagnostic challenge. There is overlap between toxidromes. Anticholinergic versus sympathomimetic, many symptoms are same. There are mimics of poisoning like hypoglycemia, encephalitis, sepsis, hepatic or renal failure. Toxidrome recognition, there are limits. It requires experience. Someone very sharp and experienced like Dr. Srinivas, he will spot on even the most difficult diagnosis. But not all patients display full toxidrome patterns. That is why I'm trying to discuss about the benefits and fallacies of toxidrome first, then going on to the classic toxidromes. There could be atypical or mixed presentations. Analytical limitations are common. Routine toxicology screen detects less than 30% of potential poison, and there are limited panels in many hospitals, usually paracetamol, salicylate, ethanol, lithium, digoxin, and many of the drugs are not tested in routine labs also. We have to send to advanced toxicology centers, which takes some time. Delay in obtaining result, if we are talking about definitive levels, we require some confirmatory tests, gas chromatography, mass spectrophotometry, liquid chromatography, and this takes a long time. New and emerging toxins, synthetic drugs, pesticides, plant toxin, and industrial agents, they evolve much faster than the testing protocols. Interference and false results. False positive and negatives due to cross reactivity in immunoassay, a big problem with urine toxicology screen. If there is improper specimen handling, hemolysis, delay, contamination, and once you have started the treatment, suppose the patient is having seizure, you have started the patient on midazolam, and then you take the samples, obviously the samples will not give the right substance. Wide range of potential toxins, variability in individual response. So individual response also varies, it depends on the dose, it depends on the timing, when did the patient had initially the symptoms could be different and as the toxidrome evolves the symptoms could change and presence of multiple substance. Additionally, they talk about the metric effects in toxicology where other substance in the sample interfere with the test can lead to inaccuracies like ketamine can give a false positive for PCP. So remember these things when you are analyzing urine toxicology or screening tests for toxicology. Only few poisonings will have very specific tests like organophosphate or carbon monoxide. So we require some syndromic approach, and the syndromic approach which we use in toxicology is toxidromic approach. Is this syndromic approach new? No, this is not new. We have been using it for a while. My first exposure to syndromic approach while was with my venerology posted STD department, where they talked about syndromic approach for treating sexually transmitted infection. Now, the syndromic approaches have been used in multiple diseases. You know, we have syndromic panels, we do syndromic analysis of sepsis. Syndrome recognition is very, very important so that we we start the treatment fast, we are specific in treatment, and the diagnostic algorithm should not consume our time while we require to intervene fast. So syndromic approach is basically case-based reasoning and tactical intelligence. We must understand it is not a compromise between reductionism and holism. It is a third path and the middle path, where with limited clinical picture and limited investigation, we have to arrive at diagnosis. It focuses on pattern recognition. It could be clinical pattern, relational data, lab, ECG, ABG, and interconnected system encompassing various other factors and confounders. So, the Toxidrome approach initially started with only clinical symptoms, but now there are ECG based recognition of toxidromes. We have ABG based, osmolar gap based toxidromic approach also. The word toxidrome is portmanteau of two words, amalgamation of two words, toxic and syndrome. It was coined in 1970 by Moffinson and Greenshire. Simplistically, it is syndromic approach to toxicology. Toxic syndrome or toxidrome is a constellation of effects comprising a set of clinical fingerprints. While we say this word clinical fingerprints, it could be clinical symptoms, clinical signs, or it could be clinical investigations like ECG, ABG, or toxicology screens. So the constellation of finding either from physical examination or from ancillary testing will give you some result. Common toxidromes which we see are anticholinergic toxidromes, cholinergic, opioid, and sympathomimetic toxidromes. So toxidrome represents characteristic and typical aspects of poisoning. However, it may not be specific to one toxic etiology. This we have to keep in mind. At times, we are stuck with the syndrome in our mind. We are stuck with the diagnosis, stuck diagnosis syndrome, I call it. So we should not have that habit for toxidromes. There is a lot of overlap. You start working on that toxidrome, but keep other things in mind, and you have to have a diagnosis of exclusion finally. You must have a specific diagnosis. Accordingly, poly or non-specific complications of toxicity can affect the clinical picture of the typical form, which is getting commoner every day. Certain drug classes or single product may induce one or more toxidromes depending on the dose, like salicylates can have variable effects on respiratory status. Nevertheless, toxidrome-based approach is helpful towards a final diagnosis and also excludes other differential diagnosis, especially in difficult clinical context. Talking about toxidromes in ICU, to quickly identify the likely toxic class, initiate immediate specific treatment, and guide clinical monitoring. It helps to monitor for early signs of poisoning in exposed but asymptomatic patients. So always remember this also. This is from Intensive Care Medicine 2025, very recent article using toxidromes in ICU. So when the signs are subtle, this toxidromic approach can help you identify the cause and give the triaging to that particular patient. This is a very, very oversimplistic approach to toxidrome. Pupil size, if it is pinpoint, look at the bowel sounds. Hyperactive, it could be cholinergic. Hypoactive could be opioids. If the pupils are normal or dilated, look at the temperature. If temperature is high with hyperactive bowel sounds, sympathomimetic. If temperature is high with hypoactive bowel sounds, it is anticholinergic. Temperature normal or low with bowel sounds, hyperactive, hallucinogenic. hypoactive bowel sounds with low or normal temperature, sedative, hypnotic. This is a very, very simplistic overview, but you have to look at every clinical picture and every clinical data in detail while you try to diagnose a toxidrome. Toxidromes in ICU, it could be a pragmatic heuristic amid imperfect diagnostic. Heuristic approach means an oversimplistic common sense approach. But there has to be some pragmatism, especially while we talk about acute care, critical toxicology. So our approach should be common sense based, but we should be very, very judicious. ICU focused toxidromes, we should have a pragmatic approach. We understand 60 to 70% involve polypharmacy or co-ingestions. More important in psychosomatic consults, psychiatric consults, and patients who have been chronic drug abusers. They unmask iatrogenic delirium, for example, from polypharmacy. So you can cut the diagnostic odysseys for chronic drug abusers also if you have a toxidromic approach. Always remember toxidromes are probabilistic, they are not pathognomonic most of the time. Some of the toxidromes could be quite pathognomonic if they come with classic signs, but not all, especially with polypharmacy. Ultimately, you have to think about Bayesian update. You have to have a stepwise approach towards poisoning. Toxidrome giving the ladder work for that, not slam dunk diagnosis, stuck diagnosis syndrome. Oh, this is this. Don't be fixed to the diagnosis, but be very dynamic and open minded for the right diagnosis. Now, if you have a toxidrome based diagnosis, you will initiate rapid empirical therapy. You have narrowed down on diagnosis. Your resource will be used efficiently and you will have good prognostic insight. It can flag severity like blood gas derangement in salicylate, and you can anticipate complications. You can use your resources judiciously. You can rule out some syndromes with this approach. We need to synthesize the findings to identify toxidrome considering the limitations. Toxidromes are usually addressed dichotomously, they are present or absent. But we all understand all diseases in the ICU, poisoning being one, is a dynamic continuum of toxic effects. And the clinical picture varies depending on the dose, depending on the age, depending on exposure, depending on recirculation of drugs and many other confounders. So toxidrome sensitivity and specificity are imperfect. Toxidromes may be incomplete with key features missing, hindering the accurate diagnosis, and many toxidromes share symptoms with other critical conditions. Always keep this in mind, especially if the patient has some complications, patient has two coexisting diseases playing around. Variability. Variability in number of components of toxidrome, variability in presentation of toxidrome. If you talk about opioid toxidrome, these are the classic components, bradycardia, meiosis, bradypnea, and coma. But not all of these components will be present in all of the patient. The typical form is this, all four components present, but vast majority of patients we see non-specific form with bradycardia, meiosis, most of the times and coma at times. So mild form of toxidromes are more frequent than severe typical form. So this is much more common. It could be this component, it could be this component, it could be this component. You see the component with all four parts are relatively rare. So always keep this in mind because toxicology and the clinical picture is always evolving and dose dependent. More than one toxidrome may be observed in the same patient. So identifying a toxidrome is challenging in mixed co-ingestions. Having said that many a times, but this is the commonest presentation now. Our data 2011 showed you a co-ingestion in 30 out of 138, roughly 25-30%, but now the co-ingestion rate is almost 60, 65, 70%. And sometimes opposing effects can occur. Speedball, sympathetic mimetic, and opioid, they can have conflicting effects. The treatment you initiate, like if you have a sympathomimetic and you initiate midazolam or a beta blocker, Again, the clinical picture will be changed and patient could be referred you from some other place after the primary treatment. Many drugs overlap in classes. Phencyclidine can cause initial sedation, NMDA antagonism, and then sympathomimetic toxidrome. TCA can trigger both anticholinergic and sodium channel blocker toxidromes. So TCA, you will have a grossly overlapping picture. Newer psychoactive substance synthetic cannabinoids, amphetamine analogs also have unique effects and generally they do not fit in any of the toxidromes classically. Toxidromes could be widely classified into these two brackets, excitatory or inhibitory. Excitatory will be cholinergic when there is cholinergic excess, like organophosphate, the commonest one, carbamates. Anticholinergic, it could be atropine, TCA, dhatura, baclofen. Sympathomimetics, cocaine, amphetamine. Serotonergic, fluoxetine, trazodone, sertraline. These are the common agents which I have discussed. Inhibitory, opioids, opioid toxidrome or sedative hypnotic toxidrome. Sedative hypnotics, vast variety of drugs will be included. Heroin, opium, benzodiazepine, barbiturate, alcohol. So remember, it could be excitatory or inhibitory. As soon as you have a patient with you, just categorize them first into excitatory or inhibitory, then follow the ladder work. Classic toxidromes historically identified substances directly, agonist or antagonist, or indirectly increase synaptic monoamines interacting with the same receptor in the nervous system. So you have to again remember it could be a direct action or it could be indirect action. And these are the commonest toxidromes which we should be familiar with. There are many more which are cropping up based on different criteria, but these are the common ones: anticholinergic, cholinergic, sedative hypnotic, opioid, sympathomimetic, serotonin syndrome, neuropeptic malignant syndrome, withdrawal syndromes. Withdrawal syndromes are again increasing in prevalence, especially if you handle your emergency or your wards also. You have to be aware that it could be a withdrawal syndrome. Neuroleptic malignant syndrome and serotonin syndrome also you should have an eye to catch this syndrome. And if you follow this toxidrome syndrome, they will point you towards this syndrome. Finally, you have to catch the diagnosis. They also talk about extended toxidromes now as we discuss. Extended toxidromes emerge as important toxicity patterns to identify agents with accessible paraclinical tests, sometimes involving specific interaction with molecular structure beyond receptors. So you have to think about these extended toxidromes also when analytics are poor and interactions are beyond the classic receptors. Sodium channel blockade, it can have effect on various receptors. Hypothermia toxidromes, electrocardiographic toxidromes are other terminologies which we commonly use. ICU, everything is very, very complex, and we do not have neat and clean poisoning patients coming to ICU most of the times. We have complicated patients. ICU milieu amplifies toxidrome pitfalls, sedated, paralyzed on agents. Your neurological examination is obscured, history is even nullified. Therapies like vasopressor, they will mimic sympathomimetic drugs and polysubstance abuse blurred lines. So the problems are plentiful in ICU. Since why we are talking about? Because these toxins can happen in ICU. We have been talking about hospital acquired toxins also. Paracetamol is the commonest hospital acquired toxicity. And we have been seeing patients with thiopenton overdose for seizure. We have seen patients with ketamine side effects. We have seen patients with tramadol toxicity and things like that. Sensitivity specificity of toxidromes hovers around 70 to 80% and 70 to 80% and best, which is far from the gold standard. So always proceed with caution. If you are over reliant on a toxidrome, you have a fixed diagnosis syndrome, then you have anchoring bias and you are incurring risk to your patient because you are not thinking on various lines and you are missing the right toxin. You could be missing the right toxin. These limitations underscore the need for vigilance. Toxidromes are imperfect scaffolds, nor blueprints. Always integrate with ECG, ABG, and if in doubt, consult the toxicology center. Google out, discuss with your colleagues who must have seen those patients much more than that. There are geographical variations and there are many other factors. Ventilated patients and other ICU patients, serial examinations, dynamic examinations, and biomarkers can mitigate blind spots. These are the problems in ICU. Incomplete or atypical presentation. Core features may be absent, like no meiosis in mepridine opioid, again, which will be a false positive. Overlap with non-toxic pathology, we have already discussed. There could be bidirectional mimicry. A patient, while you are trying to withdraw from a sedative agent, you add sertraline or some other agent, patient can have a sympathomimetic. But again, it will be very difficult whether it is a sedative withdrawal or it is a sympathomimetic excess or it is a neuroleptic malignant syndrome. Congestion complexity, diagnostic false accuracy. Again, you have to remember a critically ill toxicology patient might have a fall, might have an hypoxic ischemic encephalopathy, might have an electric shock, might be drowned. So this fixed diagnosis or heuristic common sense based bias may halt your broader workup. So always be open minded in the initial workup. And you have limited utility of novel agents. Therapeutic risk. Do not be in a haste to initiate antidotes based on toxidromes. You must have the right diagnosis and you must be using these toxidromes very, very judiciously. Most antidotes very, very judiciously. Most antidotes have a very, very small bracket of window to use them. Now, lastly, we'll go on to the classic toxidromes. We'll have a case-based approach to start with. Unknown substance overdose, the commonest presentation now to our EDs and ICUs. The undifferentiated patient. A patient is dropped off at the ED door, minimally responsive. His friends say that he took something and drove off. A young woman was found unconscious in her room with an empty bottle next to her. Where do we start? We have already discussed ABC is first, try to arrive at the diagnosis, toxidromic approach, history, search the site, ask the relatives to search the site where he consumed the drugs or the substance. Then try to arrive at the diagnosis. You have to think about hundreds of common agents while we try to arrive at the final diagnosis. Generally, we follow this two-pronged approach, treatment and diagnosis. It goes horizontally. Treatment A, B, C, D, E, F, G, airway, breathing, circulation, decontamination, enhanced elimination, focus therapy, and get toxicology help. Diagnosis, syndromic approach, history, physical examination, diagnostic test. So this has to go on horizontally. Examination is very, very important. Clinical examination, more so in toxicology because history is unreliable. Vital signs, ECG is must. Look at the QT intervals, PR intervals, and there are many, many more details which you can gather with from ECG. Blood pressure, saturation, respiratory rate, temperature, pupil size, neurological examination, skin, odors, bowel and bladder, is it hypoactive, it is hyperactive, then arrive at the toxidromic diagnosis. Again, to reiterate, toxidromes are clinical signs, symptoms associated with classic classes of toxins. It is based on autonomic effect of the toxin in question, but now the ancillary testing for toxins has also been roped in for newer toxidromes, which could be based on ECG based or urine toxicology based toxidromic analysis. Eye, skin, secretion, vital signs. Never forget these, especially in toxicology. Secretions, bowel sound, temperature, pupils. Very, very important. The common toxidromes we'll discuss now. Sympathomimetic, as the name suggests, It is sympathomimetic excess. Heart rate will be fast, high blood pressure, cardiac rhythm, it could be sinus tachycardia, but tachyarrhythmias may occur, and this could further degenerate into VT/VF. Respiratory rate, again normal to high, temperature normal to high, mydriatic pupils, skin normal to diaphoretic, secretions are generally normal. The common agents, cocaine, phencyclidine, amphetamines, ephedrine, pseudoephedrine. These are the common agents. Anticholinergic. Heart rate will be fast, blood pressure high, cardiac rhythm fast, respiratory rate again normal to high, temperature high, eyes mydriatic, skin dry, secretions dry. So the basic difference is from sympathomimic is skin is dry and secretions are dry. This is because of unopposed sympathetic tone, and the skin finding is because of loss of cholinergic innervation. So you can see vast majority of signs are overlapping with the sympathomimetic syndrome, except for skin and secretions. This mnemonic we all have been reading from MBBS days. Mad as a hatter, altered mental status, blind as a bat because of mydriasis, red as a beet, flushed skin, hot as a hair, dry skin anhidrosis, dry as a bone because of dry mucous membranes. The commonest drugs are antihistamine, atropine, baclofen, tricyclic antidepressant. TCA have variety of presentation, phenothiazine, scopolamine, datura. So this was the classic picture which we used to read about, datura. Cholinergic toxidromes. Heart rate will be slow, blood pressure normal to low, cardiac rhythm sinus bradycardia, respiratory rate will be low, temperature normal to low, pupils will be myotic, skin profusely diaphoretic, secretions copious. The commonest diagnosis here is, what is the commonest diagnosis? Someone can write in the chat box. And this is the mnemonic for cholinergic toxidromes. Sludge, salivation, lacrimation, urination, defecation, diarrhea, GI dysmotility, emesis. So bowel and bladder examination is again very, very important, and it can point towards the toxidrome and can fetch you the diagnosis very, very early. All these dumbbells, diarrhea, urination, meiosis, muscle weakness, bronchoria, bradycardia, emesis, lacrimation, salivation, setting. So these mnemonics fit in for cholinergic syndromes. Do not focus on the treatment aspect in the forthcoming slides because it depends on many, many factors and the science is variable. We are not going to discuss about the treatment at large. So the commonest cholinergic toxidromes are organophosphates and carbamates. Already discussed the mnemonic dumbbells. When there is nicotinic excess, these 2 weeks, meiosis, tremors, weakness, tachycardia, fasciculation, seizure, somnolent. Monday, Tuesday, Wednesday, Thursday, Friday, Saturday, Sunday. This is a mnemonic for nicotinic excess. So it could be muscarinic or nicotinic picture depending on the agent and depending on the time frame. Sedative hypnotic toxidrome, again a common entity. You can encounter such patients in the hospital also, coming from the ward, coming from the ED. And patients could be elderly patients, overconsumed some tablets, coexisting comorbidities. So this is again a very, very common toxidrome which we should not be missing. As the name suggests, sedation is the primary hallmark. Somnolence, loss of protective airway reflexes in severe cases, respiratory depression may occur. Autonomic effects are generally minimal. If they are there, always think about co-ingestion. If the toxidrome is not fitting, you must also think about co-ingestion if they are not fitting in a single agents. For sedative hypnotic, the features are stupor, coma, confusion, slurred speech. It could get, patient can get apnea also. Anticonvulsants, barbiturates, benzodiazepine, ethanol, opioids. Do not focus on treatment. Here, opioids. Largely, it is similar to sedative hypnotic, except Meiosis is universally present. If meiosis is not there, then it is not opioid unless it is a new smart drug which is still evolving and we are trying to understand. And respiratory depression is common and often fatal. So you must give the respiratory support as early as possible. Meiosis, bradycardia, hypotension, hypoventilation, coma. These are the classical signs for the opioid toxidrome. Heroin, morphine, fentanyl, oxycodone, hydrocodone, codeine, methadone, buprenorphine. These are the agents. Buprenorphine, again, the pupillary signs could vary. So always remember newer agents or modified opioids, modified benzodiazepine, the presentations could be slightly variable than the classic toxidromes. Beta adrenergic, tremors, tachycardia, hypotension. The drugs commonly attributing to this are salbutamol, caffeine, terbutaline, theophylline. The presentation can be overlapping with neuroleptic malignant syndrome at times. It could be overlapping with a thyroid storm. So always keep other diseases also in mind while you are trying to diagnose a toxidrome. Serotonergic toxidromes. The features could be irritability, hyperreflexia, flushing, diarrhea, diaphoresis, fever, trismus, tremor, myoclonus. Serotonergic toxidromes are not rare, especially while we are seeing a lot more of iatrogenic toxicity, especially in elderly patients or patients with comorbidity given polypharmacy, a prescription full of 15 drugs. So this is getting commoner. This is an irony. Anyways, the drugs fluoxetine, mepridine, paroxetine, sertraline, trazodone, clomipramine. So these are the serotonergic toxidromes. Treatment is generally benzodiazepines to control the irritability, hyperreflexia, and myoclonus. So this is the toxidomic approach, which is simplified figure. Sympathognomic heart rate and blood pressure will be more, respiratory rate will be more, temperature will be more. Mydriatic pupils, skin and secretions will be diaphoretic, mental status agitated, anticholinergic, heart rate BP will be more, respiratory more, temperature will be quite high, mydriatic, secretions dry, agitated, cholinergic, heart rate and blood pressure are low, respiratory rate is low, temperature is low, myotic pupil, copiously wet skin and secretions. Patient will be somnolent. Sedative hypnotic, respiratory rate could be low, skin and secretions are generally normal, somnolent to coma. Opioids, a similar picture to sedative hypnotic. Respiratory compromise is much more, it could lead to apnea. Pupils could be myotic, somnolent, and coma. Few MCQs. I'll open my chat box if the students can write in the chat box. Yeah.
Yes, they may not be able to.
Okay, okay, no problem. My screen is visible?
Yes, yes.
Okay. Is
My screen,
just a second, I will almost,
share it again.
yeah. Visible now?
It's the buffering signal symbol is coming. Yeah, now it's visible.
Not full screen.
Not full screen. Yes.
Now full screen?
Just hold on. No, not full screen.
Okay. But is it visible? I
Anyways, you can
think
discuss
few
this because
MCQs only, yeah.
yeah.
So the first question, very, very simplistic questions. We talked complexities of toxidromes. We talked about toxidromes and the common agents. Now we'll have very, very simplistic MCQs. What is the hallmark clinical feature of an opioid toxidrome? Students can judge themselves and judge me how well we discuss. The hallmark feature for opioid toxidrome is meiosis. Opioid toxidromes are characterized by triad of meiosis, pinpoint pupils, respiratory depression, and altered mental status. Hypotension and bradycardia can occur, but meiosis is hallmark feature. Second, what toxidrome is characterized by presence of agitation, hyperthermia, and dilated pupil. A common
Yes, your
one.
slide did not move.
Okay, no problem. 1 second. I'll just stop sharing and share again.
Yeah.
This is the most difficult task actually. Now, are we
Yeah.
on the second MCQ? Okay.
Second. Yes.
Moving?
Second. Yes. We are on
Yeah.
second.
Moving? Slide is moving now?
No. No. No.
Alright. Let me minimize then.
अभी मूव हुआ है.
हाँ उसको मैं ऐसे ही चला देता हूँ. Okay.
ठीक है.
Yeah.
हाँ.
So the
Yeah.
second MCQ. Thank you, Dr. Ghanshyam. What toxidrome is characterized by presence of agitation, hyperthermia, and dilated pupils? The answer is anticholinergic. Mad as a hatter, Dhatura is the classic example. Atropine, scopolamine, phenothiazine, and do not forget antihistamines now. Red as a beet, hot as a hair, dry as a bone. TCA, as we discussed, can fit in many classes of toxidromes, anticholinergic being one. Third one, a patient presents with tachycardia, hypertension, hyperthermia, dilated pupils, and agitation after suspected drug abuse. Which toxidrome is most likely? The answer is sympathomimetic tachycardia, hypertension, hyperthermia, dilated pupil, and agitation. Sympathomimetic toxidrome is characterized by symptoms of excessive adrenergic stimulation, such as tachycardia, hypertension, hyperthermia, mydriasis, and agitation, often associated with stimulant drugs like cocaine or amphetamines. Beware of the complications. It can lead to ACS, it can lead to a subarachnoid hemorrhage. So if your patient is not getting up, remains drowsy after some time, lands in shock, think about ACS, not getting up, think about intracranial bleed or a subarachnoid, specifically subarachnoid hemorrhage. Fourth MCQ. Which toxidrome is characterized by increased salivation, lacrimation, urination, diarrhea, and bradycardia? Very common. We all have grown seeing this toxin. This is cholinergic toxidrome. Organophosphate is the commonest drug in this class. Cholinergic toxidrome is characterized by overstimulation of muscarinic receptors, leading to salivation, lacrimation, urination, diarrhea, bradycardia, bronchoria, and meiosis. I'll again emphasize here bowel, bladder, temperature examination is very important in a patient with poisoning. So, practical pearls at the end for the bedside. You should track the core toxidromes, like some of them could be very typical, but do not be overemphasizing on toxidromes. Keep your mind open on alternate diagnosis, and most of the times now poisoning becomes a diagnosis of exclusion. Opioid respiratory less than 12, myotic pupils, sympathomimetic we have already discussed, anticholinergic, cholinergic, sedative, hypnotic. So these are the classic toxidromes, but seldom we see patients coming to ICU with this fixed pattern. There is a lot of overlap and there is a lot of variation because of the intervention. The workflow hack should not be disturbed. ABC first, then toxidrome hunt. Please do not hunt for poison, name, or quantity or the toxidrome. There is nothing in name. Stabilize your ABC first. Emerging nuances with rising synthetics. So you should lean on supportive care while you try to fit in your diagnosis into a particular toxidrome. When do these toxidromes ditch out? Pure metabolic like toxic alcohols, the toxidromes become difficult. Or if your toxicology screen is contradicting your toxidrome. So you must focus on the clinical picture and the clinical investigations you have with you before you arrive at the right diagnosis. And always remember, you have to treat the patient, not the poisoning. Do not treat the urinary toxicology screen. And ABC comes before Toxidrome. Thank you.
Thank you, Yash,
Thank you.
for taking through us on the various toxidromic approaches in such an elaborate fashion. It's always very, very difficult. I'm sure you
It
would
is difficult.
agree.
It is difficult.
It's
It is
very
not easy.
difficult when people come to you with unknown presentations or unknown toxicology.
Yeah,
And the idea of having a toxidromic approach is basically we are looking. Majority of the toxins have a definitive reversibility.
absolutely.
There are very, very few toxins which are completely irreversible or cause irreversible damage. So during the time period, if you do not know the toxin, if you can kind of support the symptoms, support the patient symptomatically, and hope that the elimination
Yeah,
half life of the drugs or whatever toxins is over, then the natural recovery happens.
yeah. Very
Right?
right. So we must have this watchful expectancy in toxicology also, and we should not be rushing to antidotes. We
Agreed.
must remember most of the antidotes have a very, very small therapeutic margin. And
Correct.
if the patient is in ICU or ED, the need is much less, except for very, very few subset of patients, like an ILD patient with an opioid overdose, you do not want to intubate, then you can give a trial of various antidotes. Otherwise, vast majority of patients, if you fix your ABCs and you do the right support, enhanced elimination, things should go right.
Thank you, Yes. Thank you very
Pleasure.
much.
Pleasure is
And
mine.
I know it's always difficult to remember all the toxidromes.
Absolutely.
So the lecture will be recorded on the Hicks YouTube channel. And if anybody wants to revise, please go to the channel. I'll send you the link as well. Yes, you can share it with your students.
Sure.
Thank you very much. And if you have any queries, please do get back to either me, Srinivas, or Yash. We will get back to you with the solutions. Thank you. Thank you
Thank you,
very
Dr.
much.
Ghanshyam. Have a good day. Bye bye.
Thank you. Bye.
Thank you. Thank you. Dr. Chinivas, thank you.
Thank you. Yes.
Bye.